Let me, for the sake of time, move on and turn it to Amir for a second to talk about Gemtuzumab. How do you use Gemtuzumab? Today, the FDA approved Gemtuzumab for pediatric AML.
Oh, yeah. I didn't know that. I didn't know that. Thank you. I mean, I should know that, but I didn't know that.
It was just today, you know, it was one of those things you get.
I can't comment on that, but the answer to your question is sparingly. I use Gemtuzumab sparingly. The scenario in which I definitively do use it is in patients who have core binding factor AML and who are younger, you know, and you generally combine that with chemotherapy. One of the challenges with that, of course, is getting those results back so that you have time enough to incorporate the treatment. But I do use Gemtuzumab in that setting and also use it in consolidation as well in an effort to cure them. In other scenarios, I have not used it in older patients as single therapy. I know it's approved for use in that setting. I have not used it in intermediate risk AML. I have used it a handful of times for relapse refractory disease when I don't have anything else. And nothing against Gemtuzumab, but it's not the easiest agent to give. There are infusional reactions in patients who have relapse disease. You have to worry about a history of transplant. You can dose at a lower dose and decrease that risk, but there is still that risk. And I'll be honest with you, the rate of remission is very modest, right? So rate of response very modest, high potential for toxicity in certain patients. So my use of Gemtuzumab is very low.
The other place you haven't mentioned, but I'm sure you've probably used it here, would be the high-risk APL patient. Instead of using an anthracycline, using a single dose of Gemtuzumab for a count reduction.
We've used
that's
it
the other place I've used.
Yeah, we've used it a number, especially in the last.
It's hard to get around the meta-analysis showing a survival benefit of Gemtuzumab when added to chemotherapy. We're talking about, you know, over 3,300 patients, a subset with core binding factor leukemia is clearly doing better. And some have argued, but they didn't do so well with just chemo. But actually, core binding factor leukemia, the overall survival is only around 50 to 60% at best without Gemtuzumab. And in that study, in that meta-analysis, it was in the 75% range. So I think there's something there.
I actually have been surprised by the seeming lack of knowledge about those particular data. And I guess, you know, CBF leukemias are rare. People may not see them very much, but I think it's important to emphasize on a call like this that those are resoundingly positive data. I mean, I think most of us view the addition of Gemtuzumab in the CBF, the core binding factor leukemia scenario, as in fact standard of care. And I still get consults for transplant, consults for all kinds of things for CBF patients who have not received those. And I think in particular, when core binding factor leukemias are combined with many other cytogenetic abnormalities and or a FLT3 mutation, which are scenarios that happen, I think those are the particularly confusing ones that then result in, well, does this patient need a transplant? Does this patient need this, that, or the other? And I think that we want to keep it pretty pure that if you have a core binding factor patient with or without other cytogenetic abnormalities, with or without FLT3, you probably do have a good shot of curing that patient with chemo and Gemtuzumab without doing a transplant and without switching that patient. We're asked very frequently that should that patient get 7+3 and midostaurin or 7+3 and Gemtuzumab or 7+3 and both of those drugs. And I mean, Mark is here, but I believe that the best answer to that is to focus on the core binding factor and not on the FLT3 in those patients.
We get our fish back for core binding factor within hours. And so the go Gemtuzumab is already hanging before we know the FLT3 status.
Right.
So our usual decision is it had 7+3, they've had go, and oh, what do we do with the FLT3? And we often throw it on if the patient's still talking to us.
But I actually think that people are much more, it's somehow much more prominent in their mind to be looking for the FLT3 than to be looking for the stat fish for the...
Our algorithm is find that core binding factor fast.
Exactly. So we have to emphasize that point that these are your curable patients. These are the ones where you want to call...
Some of your neighbors up there don't do that, Gail.
So, you know, I could tell you I moved to Duke 2 years ago, and I've taken a little heat for giving GO to the CBF patients as opposed to giving midostaurin alone to those patients if they're FLT3 positive. But they're getting used to me, and I'm hoping they're not going to kick me out. I kind of like Durham. It's beautiful here.